Hello, my name is Colin Coyne, and as Executive Director of Meta Global, on behalf of all of my colleagues, we'd like to welcome you to this important and timely video presentation. Meta Global is a global education service provider that seeks to connect practitioners, educators, and institutions to deliver a transformative model of healthcare education. We seek to improve the outcomes of populations by providing access to globally renowned faculty in a way that addresses present and future needs and through the lens of competency, character, and caring. The series you're going to view today addresses the essential topic of cardiac complications from COVID-19. The series is divided into 6 parts, which can be viewed individually or consecutively as one seminar. We'd like to thank our partners at Brookwood Medical Health Systems and Dr. Farrell Mendelsohn for providing access to this content. We hope that it adds to your practice. We hope you enjoy the presentations, and we particularly wish you continued good health.
Hello, I'm Dr. Donald Lloyd-Jones, President of the American Heart Association for 2021 to 22. I'm also the chair of the Department of Preventive Medicine at Northwestern University in Chicago. This presentation from the Cardiology PC Group in Birmingham, Alabama, on the CVD impact of COVID-19 should be very useful to you in your practice. I am so pleased that my former colleague from residency, Dr. Farrell Mendelsohn, was able to organize this series of presentations for your benefit. All the best to you and others in Asia as you continue to manage the COVID pandemic and the growing epidemic of cardiovascular disease. Enjoy the meetings.
So I'm going to be talking about valvular heart disease management in the age of the COVID-19 pandemic. So valvular heart disease, like almost anything procedural, has taken a big hit during the pandemic. As we all know, the procedure volume has slowed down drastically. However, we do still have patients who need care in the meantime. So this is an outline of what I'm going to go over, basically the effect of the pandemic on the volume of valvular interventions, how to triage patients, who needs to be operated on or intervened on with a catheter procedure versus who can wait until we hopefully get to better days. The new tools that have come up here in the United States over the past year, and a quick update on current guidelines for management of valvular disease, mostly focused on aortic stenosis and mitral regurgitation. So the clinical outcomes in patients with COVID and valvular heart disease was pretty bad. So we have a 30-day mortality of 42% for COVID-19 infected patients who also have significant valvular disease. This is compared to 10 to 15% in an age-matched population. So that's quite a big of a jump there. At the same time, we are not able to do as many interventions, and with all the precautions we have to take, we have seen up to a 79% drop. This was from Italy, but our numbers here are probably very similar. And the drop in procedures is more so in Watchman devices, PFO, ASD closure, and MitraClip transcatheter edge-to-edge repair compared to TAVR procedures, because in some ways aortic stenosis, severe AS, is more of a urgent valvular disease to tackle. So how can we choose who to proceed with an intervention, who to wait on? Because the priorities during this pandemic was to minimize the exposure to coronavirus for patients, as well as the structural heart team and all the healthcare workers. We also needed to maintain high quality and durable structural interventional outcomes, although the less we do, the outcomes are usually a little worse, because we're not at the same pace as we do. We kind of slow down, we lose a little bit of our skills. And we want to reduce the risk that these patients with structural heart disease, that they use resources that might be needed for COVID-19 patients. So, a lot of patients need ICU care with COVID-19, and we did not want to use ICU beds if we didn't have to. And we wanted to prevent delay of interventions in patients with high risk for clinical deterioration, heart failure, and death. So, the first section is about aortic stenosis in TAVR. So for symptomatic severe AS, those are kind of the high-risk group. For the inpatients with a reduced ejection fractions thought to be secondary to aortic stenosis, or people with New York Heart Association class 3 or 4 congestive heart failure, or syncope secondary to AS, the TAVR procedure should be considered as soon as possible to decrease the risk of clinical deterioration, prolonged hospital stay, or repeat hospitalizations. Now, for outpatients with severe to critical AS and class 3 to 4 symptoms or syncope, it would be reasonable to schedule them for a TAVR procedure. And these are people with significant symptoms. Now, for minimally symptomatic people with severe aortic stenosis, mainly people with class 1 or 2 New York heart symptoms and quantitative measures of valve severity that indicate critically tight valve, it is reasonable to consider urgent TAVR or virtual monitoring by the valve coordinator. And we've been doing a lot of telemetry during this pandemic, and it's in some ways convenient. In some ways you don't examine the patient as well, but we already know what we're dealing with most of these patients. So if they have any signs of deterioration that they report to us, then we can go ahead and consider the TAVR procedure. Now, the data to date are not robust enough for this group of patients to give firm recommendations, so it's basically tailored from patient to patient. The features that warrant consideration are basically people with high peak or mean gradients by echo, very small calculated aortic valve area, and very low dimensionless index, or all indicators of critical aortic stenosis. Now, for asymptomatic severe AS people, we need to make sure they're truly asymptomatic, because patients have a tendency to underreport their symptoms. But for those ones, it is reasonable to postpone the consideration of TAVR for 3 months or until we are resuming elective procedures, like normal times. In the meantime, close outpatient monitoring via telemedicine should continue for all patients with severe aortic stenosis. Now, coming to the second part is mitral regurgitation and transcatheter edge-to-edge repair, also known as the clip procedure. Most of these patients, have chronic disease and are to some extent compensated, so most of them can be safely deferred. However, in some select patients, we should consider these procedures earlier, such as in patients with severe functional MR, 3 to 4 plus MR, who cannot be discharged despite optimized GDMT, and patients with CHF, severe degenerative MR, due to valvular dysfunction, and who are at high risk for surgical mitral valve repair or replacement. Outpatients with severe functional MR with hospitalizations for heart failure, decompensations within 30 days despite medical therapy. Outpatients with severe degenerative MR with hospitalization within 30 days despite medical therapy, who are at high risk for surgical interventions. Patients with severe degenerative or functional MR who are in low output decompensated heart failure and requiring ICU level care, in whom we think we can improve hemodynamics by performing the MitraClip procedure to help extubation, weaning off pressors, or transferring out of the ICU. In those patients, we also would consider this procedure. Now, for valve-in-valve transcatheter mitral valve replacement, these are usually for either severe prosthetic MR or mitral stenosis. Valve-in-valve TMVR is the only approved intervention by the FDA, not unlike valve-in-MAC or valve-in-ring, which are more off-label procedures, but we'll talk about that in a second. So these procedures are very resource-intensive, complicated procedures, should be deferred until after the pandemic is over, provided patients can be sufficiently managed on medical therapy. Now for valve-in-valve tricuspid mitral valve replacement during COVID-19, people with severe MS or MR who are inpatient, with CHF or outpatients who have had hospitalization within 30 days despite medical therapy, we would consider doing those. Now valve-in-ring and valve-in-mac are off-label and are much higher risk, and usually we try as much as we can to avoid these procedures altogether, especially that we need to have TEE involved, and these patients have a tendency not to do very well. Now for perivalvular leak closures, these are also lengthy procedures. We try to avoid doing these if we can. And it should be considered if patients have heart failure symptoms and or hemolysis. So these are the two strong indications to go ahead with peri-leak closure during the pandemic. Now, as we are going through the pandemic, we have had new devices come up. So the medical field is always progressing despite all that's going on. One of the new tools we got was the Sentinel Cerebral Protection System. It's by Boston Scientific. We introduced this through the right radial artery, and basically we have two filters that we place in both carotid arteries in that manner that you can see in the picture. It's been reported up to 25 million neurons and 1.4 billion synapses are damaged due to small particle embolization. These seem like scary numbers, but I'm sure it's probably much less. Probably we couldn't see that on a CT scan. But the device protects 90% of the blood flow to the brain, and in the trial, there was debris in about 99% of TAVR patients, and 15% had debris more than 2 millimeters in size, which is quite big. And it was reported that there was a 63% reduction in stroke rate. Now, I was reading something that came out maybe 2-3 weeks ago about real-world experience with this device, and it didn't really pan out. It didn't show a significant reduction in stroke rate. So, these are probably going to be devices that we use in specific patients, not in everyone. Now, we also obtained this Manta large bore closure device. It has a scary name, but basically it's a big plug, collagen plug, that we can use to close up to 25 French arterial device sheath or cannulations. We have used it in arterial closure of ECMO devices. We use it mostly for TAVR procedures, but it's been proven to be very easy to deploy and very successful so far. So we got a new valve that we started using, and shortly after it was removed from the market. It's the Boston Scientific valve, and it was removed for basically they report complexities with the delivery system. These procedures that we've done here with these valves did take much longer than we did for other valve procedures, but they were pretty successful. The highest risk with these valves was basically the high pacemaker implantation rate. The biggest advantage was you could deploy the valve entirely and retrieve it entirely if you don't like how it sits. So they might be working on some other iteration of this, but we have yet to see. Now, MitraClip has introduced its 4th generation clip device. This is basically, we have now 4 different clips. The NT is what is the traditional clip. The NTW is wider by 2 millimeters, so we can get more tissue, and we have seen with this new device that single clip procedures have become more common compared to before, where we needed more than one clip to have a good result. XT has bigger arms, and XTW has bigger arms and is also wider, and these are for the people who have a bigger gap between the mitral leaflets. We also have independent grippers that we can use, so this basically making the procedure much easier, and getting the leaflets has become more successful since the introduction of this new system. Now, in terms of guideline updates, I'm going to start with TAVR updates. The TAVR valves that we have, we're going to look at the first two since the third one is not in the market, is the Medtronic Evolute. It's a self-expanding valve. It's a supra-annular valve, so basically the new valve sits above the position of the old valve, and the advantage of this is we can get much bigger valves there, better hemodynamics. The disadvantage is it has more peri-leaks and slightly higher pacemaker need. The Sapien 3 is the Edwards valve. It's the first valve that we had approved. It's balloon expandable, it has less peri-leak, and it has a higher rate of bundle branch block, left bundle branch block. So the first valves, first TAVR was placed in France in 2002, and we've come a long way, where we can see as of 2017, if we look at the data, if we take surgical AVR and AVR and CABG versus TAVR, TAVR has higher number than surgical aortic valve replacement as of 2017, which is quite impressive. And obviously, initially it was a high-risk, exclusive high-risk patients that used to be candidates for TAVRs. Now we've moved to intermediate risk, and more recently to low risk. So you can see here TAVR is class 1 for prohibitive surgical risk, high risk, and was class 2A. That was 2017. So this diagram is from the guidelines of 2017, and I'll show the most recent one from 2020. But low surgical risk would be class 1 surgical AVR. There wouldn't be a place for TAVR there. So these are the big trials over the course of the years, and we can see on the bottom right the Partner 3, which is the Edwards low risk valve, and the Evolute LR low risk for the Medtronic valve, which were completed somewhere between 2017 2018. Overall, there was, a statistically significant primary outcome decrease, which in Partner 3 with the Edwards valve was death, stroke, rehospitalization at 1 year, 8.5% versus 15%. We can see here the rate of new left bundle branch block is pretty high, 23% versus 8% with surgical aortic valve replacement. Now for the Evolute valve, death or disabling stroke at 2 years was 5.3% versus 6.7%. And we can see the gradients are much lower with the Evolute valve compared to the Edwards valve, and this is because it's usually we can implant a bigger valve, and because of it being supra-annular. I don't know how much you guys can see this, but can they see a pointer or no?
Yeah, they can see it.
With the mouse? Okay. So the biggest thing, this is from the 2020 guidelines. Here we can see an introduction of what they call shared decision making with the patient. Now that we have shown that TAVR is also a good option in low risk, there needs to be a lot of discussions with the patients and have basically make a decision with the patient about what they prefer, and talking about the advantages and risks of each procedure. So we can see here on the right side, when it's high or prohibitive surgical risk, TAVR versus palliative care are really the two options. When a patient is below 50, usually still surgical aortic valve is recommended, and usually mechanical aortic valve rather than a bioprosthetic valve, because they're so young, unless they have a contraindication to Coumadin. When they're 50 to 65, we can do either a mechanical or bioprosthetic valve. Now, when it's more than 65 years, we go for a bioprosthetic valve most of the time, especially now that we can do valve-in-valve procedures, and we have shown that a TAVR inside either a surgically implanted or prior transcatheter implanted aortic valve, we're having pretty good results, and these last for about eight years or so. But if we go all the way to the bottom of the diagram, we can see that still when patients are below 65, we recommend surgical aortic valve. These people usually are the bicuspid population when they have severe AS at such a young age. So the anatomy of the bicuspid valve is a little bit more challenging for a TAVR, although the Medtronic valve has been approved for bicuspid valves. Now here is the biggest change: is age 65 to 80. We used to have TAVR as a class 2A, and now it is a class 1 indication. So that's the biggest change. And when we hit an age of 80 or more, we're looking at class 1 for TAVR and 2A for surgical aortic valve. So these are definitely promising changes as we move more towards transcatheter procedures. Now, this is a new update on the PARTNER 3, so the Edwards trial. They have seen that the differences between TAVR and SAVR at 2 years, the gap has closed. So the gap that was in favor of TAVR has closed down a little bit. Still, there is a statistically insignificant advantage to TAVR, but it's 2.4% death versus 3.2 at 2 years, and 2.4 stroke versus 3.6. The only thing that remains that remains statistically significant is rehospitalization. It was 8.5 versus 12.5 with a significant p-value. Now the downside, what they've noticed is that there's a higher rate of valve thrombosis in TAVRs, which is 1% versus 0.2%. That was at 1 year, and at 2 years now there is a significant difference. Now 3 out of 4 of these patients were asymptomatic, but they did have an increase in valve gradients, and usually we put these patients on anticoagulation and hope that the valve thrombosis, the thrombus goes away and the gradients normalize. Now for transcatheter edge-to-edge repair, so just going over the basics, we classify mitral regurgitation based on the Carpentier classification. So you have type 1, which is normal leaflet motion and position, type 2 with excess leaflet motion, type 3A with restricted leaflet motion in both systole and diastole, and 3B, which is restricted leaflet motion in systole only. So you can see primary MR is basically a primary valvular problem. Secondary MR is normal valve with something else causing the leakage to happen. And what we look at in terms of Carpentier type 1, there's left atrial enlargement and annular dilation due to this. Or in non-ischemic cardiomyopathy patients, you have a stretch in the annulus due to the enlargement of the LV. And then you can have ischemic cardiomyopathy, where you have a tethered leaflet due to a low motion abnormality, and you have usually an eccentric MR jet, and that's usually in systole that the valve doesn't close, and there would be a coaptation gap causing the MR. So most of the studies initially were about primary MR or degenerative MR, and now we are moving towards fixing secondary MR or functional MR, and these are where the biggest updates have happened. There has been, compared to TAVR, MitraClip has not had studies for quite a bit of years. We can see a big gap between 2011, with the biggest trial back then was Everest 2, and then 2017 when we had Mitra FR and COAPT, which changed the way we treat functional MR. So these are the 5-year results of Everest 2 for degenerative MR. An advantage of CLIP over surgery with less death, mitral valve surgery, or severe MR. Although each and every one of these factors, were, either not statistically significant or showed maybe an advantage to surgery, but it proved safety to use this device. Now, MITRA-FR and COAPT were both studies about functional mitral regurgitation. And MITRA-FR was overall a negative study, while COAPT was definitely in favor of using CLIP. So the biggest difference between these two studies, which was very controversial when the results were published, was basically how they describe the severity of MR. And by European guidelines, severe MR has an effective regurgitant orifice area more than 20 millimeters square, or regurgitant volume of 30 cc's, while our guidelines here, the regurgitant orifice area should be more than 30 millimeters squared, or regurgitant volume more than 45. Also, the EF in MITRA-FR was lower, and the ventricles which much more dilated, and basically, the studies had, kind of a same population, although the severity of MR, we had much more severe MR with COAPT compared to MITRA-FR, and again, the diastolic dimensions were much bigger in MITRA-FR. Also, COAPT, as you can see, they used, a little bit more clips. They had less moderate to severe MR at the end of the procedure and at 2 years. So we are thinking maybe the operators were much more diligent about their end result. And overall, there was statistical significance with mortality 19.1% versus 23% in the control group, which is just guideline-directed medical therapy without the clip. Also, there was a significant reduction in heart failure hospitalization and mortality or heart failure hospitalization. With MITRA-MR, nothing was basically different between the two. So what to do with that? So the way we're dealing with this is anytime we want to consider somebody for CLIP, we are looking at severe MR per our guidelines, not European guidelines. So we want more regurgitant volume, more regurgitant orifice area. We want smaller ventricles, and we want a slightly better ejection fractions, because we think that MITRA-FR, these patients just had bad heart failure rather than significant MR. Hence, this is why they didn't have any benefit from the CLIP procedure. Now, these are the guidelines, the newest guidelines for CLIP. It's basically, for primary MR, it's a two-way in high or prohibitive surgical risk. That hasn't changed much. Since I'm running out of time, I'm going to jump to the more important slide. Is for functional MR. Now we have 2A indication for patients with EF less than 50% who have symptoms on medical therapy, and we have some considerations where you have a good anatomy of the mitral valve, so we can think we can have a good result with the CLIP, EF of 20 to 50%, and a LV end systolic diameter less than 70 with a PA systolic pressure of less than 70. And this is two-way. It used to be 2B. And this led to an extended coverage by CMS. So now Medicare patients are covered. This is as of June 2020, which was great news. So now we can start treating these people. So the COVID pandemic has been challenging to all of us, and we have learned to adjust to it and to keep on moving forward, and hopefully we can get to the end of it. Thank you, everyone.
Today I'm privileged to provide a brief summary of the lecture that you've just heard related to valvular heart disease management in the age of COVID-19. It won't be a surprise to any of you what was said in the presentation, that the outcomes are poor in patients with COVID-19 who have structural heart disease before they contract the virus. The mortality rate in these patients in one study was 42% compared to a mortality rate of 10 to 15% in patients without structural heart disease. So one of the things that's happened in all heart disease, and particularly in structural heart disease, is a decrease in the number of procedures that have been done. This is a result of two issues. One, just simply how crowded our hospitals are because of COVID, and many elective procedures stopped by health authorities during this time of management of COVID-19 patients. And then, importantly, the fear that our patients with chronic disease have to come into the healthcare delivery environment while the COVID-19 is still such a problem and highly contagious. So, likely the most important thing that was said to clinicians in this presentation, that for patients with heart disease, including valvular heart disease and structural heart disease of other kinds, that the most important thing you can do for your patients is to help them prevent getting COVID in the first place. So they should use every measure available. Now that vaccines are available, they should certainly avail themselves to the opportunity for vaccines, and they should continue to use other measures such as face mask and social distancing. The common procedures that are being used now, the non-surgical procedures for the aortic valve and the mitral valve, can continue in this environment. The transaortic valve replacement procedure, TAVR, can be done in patients with aortic stenosis who meet the criteria, the usual criteria for needing the procedure, and mitral clip procedures can be done in those patients with mitral prolapse and regurgitation. So the patients who need these procedures should have them in the same indications that they have in the non-COVID situation. And for patients who do have mechanical valves or have valvular problems and then contract COVID-19, particular attention should be seen for them. They're more likely to have the acute complications, the cardiopulmonary complications. So thank you for listening to the presentation today, including this brief summary, and I wish you well as you continue to take care of your patients with COVID-19. Thank you.
Greetings, my name is Dr. Charlie Sands, and I serve as chair of MedEd Global's advisory board. As an international medical education service provider, MedEd Global is excited to have provided this outstanding review of the cardiovascular complications of COVID. Our mission is to promote superior education and training for international healthcare personnel. I sincerely hope that this educational video has proven to be of help to you and your colleagues. If you'd like to discuss ways in which you can support or become a part of MedEd Global, our contact information will appear on the screen momentarily. Thank you for the opportunity to share this important information on the cardiovascular complications of COVID.